Hello, everyone, and welcome to our Capstone Defense, in which Geil, myself, Peola, Fairuz, Janine, and Jaspreet are a part of the Sickle Cell Disease Management, Advocacy, and Resources for Transitioning Youth team, and we are excited to present our work.
Our capstone would not have been possible without our advisory committee of Dr. Richard Fody, Dr. Edyta Marcon, Serena Thompson, James Bradley, and Dr. Jim Slotta. Here's an overview of what will be covered today. As we gather virtually on Turtle Island, I invite you all to acknowledge and give thanks for the traditional land you're situated on at the University of Toronto. That is the land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. So to start off with background on sickle cell disease, or SCD for short, I pass it to Fairuz.
So SCD is a genetic condition characterized by sickle-shaped red blood cells that are prone to clumping together, blocking oxygen flow, and causing acute pain crises. While some pain crises can be managed at home, severe ones need emergency department or ED visits where pain medication must be administered. In Canada, there are about 6,500 cases, with the majority in Ontario, primarily in Toronto and Ottawa, with the average age being 24 years old. And while there's limited racial data in Canada, stats from the US show prevalence to be higher amongst Black individuals, with 93.4% of diagnoses compared to 1.8% of diagnoses amongst white individuals. So the shift from pediatric to adult healthcare is a critical phase, as there has been a rise in mortality shown between 20 to 24 years old, coinciding with the time of transfer to the adult care system. Studies reveal that doubt from healthcare providers contributes, as patients report skepticism from providers regarding pain treatment. This doubt will often stop youth who have already transitioned into the adult system from seeking care. In fact, a study found 88% of youth 21 to 25 years old will actually delay seeking ED care until their pain is at an 8.7 on a 10 scale. Evidence also suggests racial bias in pain perception and treatment, where one study found that within the ED, children with SCD, of whom 88% were African American, face longer delays in receiving pain medication compared to children with long bone fractures, among whom only 15% were African American, despite both having high priority triage needs. Other challenges within this time period are the lack of familiarity and awareness of SCD among adult care providers, difficulty in transferring care responsibilities from caregivers to youth, and differences in the culture of care between pediatric and adult EDs, in which the adult ED seems isolating, non-compassionate, and non-communicative. So to better understand the state of transition programs as well as the needs of youth, we conducted an environmental scan consisting of informal interviews with patients and healthcare providers, as well as a literature review of transition programs for SCD and other chronic conditions like diabetes. From this, one recurring theme was found, which was the need for support from healthcare providers throughout transition, including preemptive support to ensure that youth feel transition ready.
Now to move on to our research purpose. Our project identified that youth with sickle cell disease receiving care at pediatric centers need ongoing support as they transition to adult care centers. Our research question investigated how transition readiness can be increased to improve outcomes for youth with sickle cell disease. And our capstone's goal was to use a participatory design approach to create a low-fidelity prototype to enhance the transition readiness of youth with sickle cell disease during this transitionary process in Ontario. So where did we land? Our team is now working to create an educational module for healthcare providers in adult care, focusing on the transition of youth with sickle cell disease from pediatric to adult care. So how did we get there? For our methods overview, we used a participatory design approach through co-design and community consulted design practices. In total, there were 6 sessions as shown in the diagram here. This is a visual of our process flow. The red illustrates our 3 participatory design sessions, whereas the blue represents our 3 internal team sessions. For our recruitment procedure, our team emailed multiple organizations, like Sickle Cell Awareness Group of Ontario, or SCAGO for short. We reached out on social media, and we asked for people in our networks for referrals. Finally, participants were recruited through referrals from SCAGO, sickle cell disease advocate Serena Thompson, and transition navigator James Bradley. Lastly, it's important to note that a thematic analysis of the first design session was conducted to gain insight into the experiences, viewpoints, and current state of the transitionary process. Now, to dive into some further detail with our process flow, these sessions were mapped out based on the human-centered design scaffolding process. Session 1 verified our understanding to define and frame the context. In Session 2, we developed a criterion for design requirements. And in Session 3, we ideated concepts based on these design requirements. Session 4 validated the findings to translate into tangible concepts. In Session 5, we focused on testing and iterating the prototype design. And finally, in Session 6, we developed the low-fidelity prototype.
So now our results and discussion. So for our first design session, we had a total of 6 participants. 2 of them have SCD, 3 have lived experience and healthcare background, and 1 is a nurse practitioner. To examine the current and desired state of transition goals, we developed activities for 3 phases. 1, where are we now? 2, where do we want to be? And 3, how will we get there? We started off with general brainstorming, then converged and did other activities, such as persona building, the 5 whys, and how might we's. We brainstormed with the entire group and conducted activities in Zoom breakout rooms. For further detail on one of the activities, we want to briefly show the results of the persona building, as they were used throughout the design process. Personas were an activity to first understand the transition journey further. Second, think about them during our team sessions when selecting design requirements. And lastly, testing the intervention to know which is the most desirable and feasible. Participants created the following personas. So first is George. He's a 19-year-old Black male living at home. He wants to go to school and move out, but can't afford it due to high costs of living. Next is Anna, a 21-year-old Black female who's in the upper middle class. She is living away from home on campus and facing challenges with independence. And last is Chris, an 18-year-old African-Canadian male living at home with siblings who just graduated from high school. He wants to be a healthcare worker but struggles with self-confidence due to having SCD while his siblings do not.
So now for design session 1, we completed a thematic analysis as well for 2 reasons. One was to verify the current state of transition, and the second was to verify our findings here with the environmental scan findings. And this analysis was developed using the Braun and Clark framework. Importantly, an analysis of the second and third design sessions were not conducted, as those focused on collaborative ideation. So this analysis was done in 3 steps. First, the Zoom transcripts were de-identified, exported, and then uploaded into Quarkus. Secondly, we individually coded a small sample of the data to create initial codes, and then we met to create a shared codebook. Then we coded the remaining data using the codebook. And finally, we met at the end to group codes into themes. So on the screen, we've shared how each subtheme and their codes were grouped into Quarkus. From this, we had one main theme of barriers to successful transition with 4 subthemes on 1, lack of education and awareness, 2, limitations in healthcare delivery, 3, navigating multiple transitions, and 4, racial bias in healthcare. So to put it all together, we generated a word cloud where you can see that the most prevalent word was hospital, indicating the central role that it plays in healthcare transition. Another important word was person, and another was education, emphasizing the importance of person-centered care and the need for greater SCD awareness and education. So what were participants saying for each subtheme? In lack of education and awareness, a participant noted healthcare providers' unawareness of SCD in the ED, leading to symptom dismissal and inadequate care. In navigating multiple transitions, it was explained that youth simultaneously handle healthcare and life changes like school and work causing stress. In healthcare delivery limitations, participants explained that while there are protocols in the ED for pain crises, there is limited accountability in practice. And finally, in discussing racial bias in healthcare, participants described persistent myths and stereotypes about pain tolerance and drug seeking, contributing to racial bias towards Black individuals with SCD in pain treatment.
So next, the participants identified barriers to transition to help us narrow our capstone focus. They selected 2 issues to tackle. First, self-management of SCD, and second, providing holistic healthcare. Participants then identified the root cause, which is the lack of HCP training and awareness specific to transitioning youth with SCD among adult care providers. For example, in internal medicine and the ED, as well as other areas of the adult healthcare system where encounters may occur. And to tackle the root cause, participants of Design Session 1 shared potential interventions. First are mini cards with personal information of patients and protocol guides. Second are workshops tailored for target audiences to learn about SCD. Third is support from a transition navigator for youth. Next, a digital module for healthcare providers to learn about SCD. And lastly, peer support and mentorship.
Now, the purpose of the first team session was to develop criteria for design requirements to set the design direction moving forward. The interventions developed through ideation with the participants were evaluated using a feasibility and desirability matrix to determine if they meet the needs of youth with sickle cell disease, while also considering the team's resources and expertise. The most feasible and desirable interventions were the digital module, lunch and learns, and mini cards.
All right, so now moving on to the results of Design Session 2, where we had a total of 7 participants. So they discussed for an hour and decided to move forward with 2 interventions, workshops and creating a digital module. So for the workshops, they could be for healthcare providers in internal medicine, where individuals with SCD can lead the sessions and educate them about the disease. Next is an online module for healthcare providers in the emergency department. The focus is on empathetic communication with patients and being accountable for the care they provide.
So based on the discussions with participants and the internal team, the creation of a digital module was chosen as the most appropriate intervention to move forward with to improve the healthcare patients with SCD receive through healthcare provider education and translatable SCD healthcare practice. Again, this intervention highlighted the importance of empathy, compassion, and accountability in continuing education, in which research shows that empathetic healthcare providers who understand their patients report better patient outcomes, which is what is needed to address the patient-centered needs.
So from this, we moved into Team Session 2, where the purpose was to validate the findings from the previous design sessions to translate into tangible concepts. In this session, the internal team analyzed the insights around the personas developed and the participant experiences to start developing a low-fidelity module framework for the digital module.
Before creating the plan, we considered findings from participants and the literature. Participants shared that there is disjointed care once the transition occurs from pediatric to adult healthcare. This means that their care coordination is no longer centralized to a team of healthcare providers. Instead, they are expected to manage their healthcare with limited support. Participants emphasized that their experiences with many adult healthcare providers reflect limited knowledge of SCD, thus affecting the quality of care. These findings also reflect the barriers identified in the literature, including the lack of training and experience of adult healthcare providers in SCD, stigma towards SCD, and the perception of drug-seeking behavior when seeking treatment. These barriers not only widen the health inequity gap within racialized populations, but also decreases the quality of healthcare and further reinforces the aspect of self-dependency even during life-threatening health crises. Recently, Ontario Health administered the quality standard of care for sickle cell disease, emphasizing the importance of care that is free from racism and anti-Black racism, comprehensive healthcare plans, treating and managing chronic pain, and viewing treatment holistically. Importantly, these standards are also reflective of the literature and what participants shared. However, despite the administration of this document, it does not ensure standardized healthcare delivery. So while considering the literature, health quality standards, and the voices of participants, the 5 components of the plan for the framework were mapped out, and they were presenting the disjointed care in sickle cell disease transition and gaps in quality of care, together with the need for healthcare provider education, as well as tackling the emergency department, sharing up-to-date guidelines, protocols, and the initiation of triage. discussing psychosocial factors connected with sickle cell disease, such as relationships, education, and work, lifestyle, finances, and family or caregivers. Discussing compassionate and empathetic communication. Healthcare providers need to communicate in understandable language, be aware of anti-Black racism, and be mindful when working with youth, since this is an impressionable age group that would have a viewpoint about the healthcare system based on earlier experiences. And discussing youth engagement, where we would introduce strategies for patient and family-centered care, how patients can have an active role in care planning, and share different types of resources.
So lastly, for design session 3, we compiled our findings and plan for the online module. We then presented this plan to participants to get their feedback for iteration. After presenting our plan for the low fidelity module framework, the participants found all of the topics to be important for transitioning youth, but they asked us to be cautious about the ED section because it may already be part of other existing learning modules. Participants also asked how we'll disseminate the module to care providers with patients who have SCD.
Now for our last session. Our goal was to develop our intervention, which was the low fidelity module framework. So the moment everyone's been waiting for, time to hear more about our intervention. After integrating the feedback from the last design session, the 5 key components of the plan were translated into section headings of a low fidelity module framework. In the framework, we've included an introduction and conclusion, and we'd also like to note that we are integrating the resources and tools as well as the assessment and evaluation sections throughout the module, rather than providing them with separate components.
Those section headings were then iterated to create a fuller version of the module framework with topics for each section heading. So here are the following learning objectives. Number 1 being the need to identify the unique challenges faced by youth with SCD as they transition. Number 2, developing effective communication strategies and care coordination techniques to support youth. And number 3, implementing comprehensive patient-centered care plans for youth with SCD as they transition. In thinking about how to further develop the framework into a module, our team came across the Sickle Cell Disease Education Program for Healthcare Providers through SCAGO, which provides accredited learning modules on SCD for healthcare providers. We've been in contact with Karen Fleming, the education coordinator of these modules, to determine how we can work in partnership to develop a module on SCD transition for healthcare providers. So we are now working with Karen as well as James from our PAC. After connecting with Karen, it was decided that Module 9, as you can see on the left here, was originally going to be on vaccinations. The SCAGO team moved this content to be covered in another module so that we can now have a module focusing on transition for young adults and adolescents with SCD. These are screenshots available from the website. So while these modules are being developed, we are discussing future partnerships with Dr. Andrew Pinto, who is the director of the Upstream Lab at St. Michael's Hospital, which tackles issues on social determinants of health. Partnering with Dr. Pinto will support us in developing the module with an equity lens and further disseminate the modules in clinics across the province, as there will be many pilot test partners available throughout the Upstream Lab network. This includes potential organizations such as Taboo and the Black Creek Community Health Center. So here's an example of a SCAGO module on the left that is already completed. Our key 5-section headings on the right from our module framework will ultimately be translated into the SCAGO module format. We have many directions we hope to take in the future. Firstly, we want to take the framework and actually finalize the module with SCAGO, which will eventually be published. After this, we aim to examine the broader implications for our design work. Design work can sometimes be specific to the group of people involved, and we will be working to see how our work can be potentially disseminated to other audiences, including school administrators and workplaces. And while our process included the voices of people with SCD or healthcare provider backgrounds who are adults, we recognize that there are other opportunities to engage youth. The STEAM Design and Summer Mentorship Program at University of Toronto reached out to us, who work with high school students in tackling healthcare and innovation challenges. They were curious about our project, and we are discussing how we can collaborate with them in the fall to work with and engage youth to support the research in SCD transition space. Thank you so much, and we look forward to your questions.